panels. So the first speaker is Dr. Abhimanyu Sharma. Polymerase chain reaction in viral anti-uveitis with secondary glaucoma, analysis of 28 eyes. The first one is this one, Haryana. Okay, sorry. So the Haryana Ophthalmic Society, the first paper is choroiditis diffusa acuta, an unusual diversion by Abhimanyu Sharma. Correct?
Yes, sir. May I start, sir?
Yeah, please start. So your timer is ready?
Yes, sir.
Excuse me? Yeah, you all are ready, no? Start. Yeah.
Okay, so this was the term used by Harada himself. Before they arrived at the acronym of VKH. So we had a 29-year-old male, sudden onset diminution of vision in the right eye since the past 5 days. Visual acuity was finger counts at 1 meter, anterior segment was within normal limits. And he had a history of fever 4 days prior to the episode. And on examination of the posterior segment, we saw active vitritis, peripapillary subretinal fluid, hemorrhages, hypopigmental chorioretinal lesions, and premacular hemorrhage. So on OCT, we can see the SRF and we can see the heme. Left eye was significantly, it was doing okay. There was no significant findings. In hindsight, now we looked at it, there were very subtle ILM folds and OCT was grossly normal. So we went into the differentials looking at, impending retinal vein occlusion, syphilis being the great mimicker, tuberculosis, Valsalva retinopathy, and blast crisis. So we order a battery of tests that include your blood counts, treponemal antibodies, your gold standard, Montox, and the entire panel. So 4 days later, he comes to us. Now the left eye, the visual acuity is dropped to 624. We have parafoveal choroiditic lesions, neurosensory detachments, subretinal fluids, and active vitritis. So we do an FFA, we can see some early pinpoint leaks, right, and late pooling in the disc and hyperfluorescence in both the eyes, which was seen. And on ICGA, we saw hypersenescent vessels and multiple hyposenescent dark dots. And these were the fuzzy vessels which were seen in the peripheries. So an working diagnosis of VKH was established, and oral steroid therapy with 60 milligrams of methylprednisolone was started. So the patient was on recovery 4 weeks post oral steroid therapy. The left eye recovered to 6.6 and N6. But the right eye, we had a visual acuity of N6 by 36 and 18, and there was sub-ILM heme. So we advise that you go in for a right eye vitrectomy with ILM peeling and sub-ILM heme removal. So this is the video of the surgery. So we stain the ILM. ILM becomes very tenacious here when there's blood underneath. So this is 3 weeks post-op, the right eye. He's doing pretty good now. He's 6 by 6 parts. With correction, he's 6.6 now. And key points I would like to point out in this case is that it's extremely important to rule out systemic conditions. We have to use the diagnostic modalities here. At the first go, we did not think of using FFA and ICGA. It was only done later on. And immunosuppressive therapy, we have to combine it with azathioprine and cyclo and CPs, because the patient just came back to us recently with the same symptoms again, and surgical intervention whenever it's necessary has to be taken. Thank you.
So why do you think was the hemorrhage in this patient in this one eye?
Sir, so there were two theories which we came to. Number one was that there was a very strong perivascular adhesion with the vessel. So we aren't really sure about it. The second one was that there might be a vascular anomaly. We did do an octa for it. I don't have the images for that. So but because he was already operated, we couldn't actually trace the anomaly. So these are the two theories which we could come down to.
And in the eye, which is weakage, there's so much of inflammation. When you're going inside, the retina can be very friable,
Yes,
you know.
absolutely,
So I think
sir.
you have to. Why didn't you do a solumedrol? I was wondering in this patient if that's such severe weakage. I was wondering.
So it was the first. It was the first attack. That's why probably.
So you waited for the inflammation to totally
Yes,
subside, and then you
four,
went. So
4 to 6, fifth week we operated
week,
him, sir, with steroids.
Very nice case. Yeah, I think it's very nice and nicely documented case.
Thank you.
Just one question. For azathioprine, what are the prerequisites in your institute?
So, ma'am, usually in my institute, we don't start it at the first go. We obviously start with the steroid. It can go up to 6 months as well. Some people do that. But I think so in LFT and KFT, before starting the azathioprine is a must.
Do you get a genetic evaluation done or just keep a close follow-up?
In our institute, we don't do that usually, but I think so it should be done.
Should be done. Do you do that?
I don't do in my case, but I just follow up with the blood count.
Yeah, blood
routinely.
count is absolutely.
That's the most important thing in
LFT, KFT
azathioprine.
and the blood
Yeah,
count,
yeah.
has to be done.
A very interesting case. And how do you follow up such patients? What is your protocol for that?
So, ma'am, usually we look at them at every 3 to 4 weeks. Like the surgical eye, once it's done, 3 to 4 weeks has to be taken into account. And initially, when we are treating them for acute cases, 2 weeks has to be followed up. The patient has to follow up every 2 weeks.
With your regular blood count also to be
Yes,
taken
yes.
consideration. Right.
Can go on to the next.
Good. Next, I think yours presenting the next one.
No, sir. There's a confusion in the.
So next.
Polymerase chain reaction.
Okay, yeah. So the second paper is polymerase chain reaction in viral anterior uveitis with secondary glaucoma, analysis of 28 eyes. The author is Bhavini Johri. Yeah, sorry about the confusion. Okay. तो first वाले का marks नहीं है ना उसका?
इसका मार्क्स नहीं?
है क्या?
ये है ना हरियाणा ऑप्थेल्मोलॉजिकल सोसाइटी यही था ना इसका?
तो वो उसमें उसको भी marks देने हैं क्या?
I think
ये भी
so, ना? नहीं देने
दे देते हैं. Just mark it. If you want. I don't think it's part of this. Yeah, you can start. Please start.
Good morning, everybody. Today I'm going to be presenting a paper on polymerase chain reaction in viral anterior uveitis with secondary glaucoma. We have done an analysis of 28 eyes from a tertiary care center in South India. So as we all know, viral anterior uveitis can be caused by CMV, VZV, HSV, and rubella, and secondary glaucoma develops in around 10 to 40% patients. Now, precise detection of this virus is essential for effective control of anterior uveitis as well as the intraocular pressure. And here is where PCR comes to help us. So this study is unique since we have included patients of viral anterior uveitis who developed secondary glaucoma. And most studies are based on results of real-time PCR, but we have also carried out nested PCR. So this was a retrospective study. We included patients who were clinically suspected to have viral anterior uveitis with secondary glaucoma and underwent an AC TAP from 2008 to 2024. And we excluded patients with glaucoma prior to the onset of viral anterior uveitis. Our sample size was 28 eyes from 23 patients. The AC TAP was done in the OPD at the time of the first episode, and we sent the sample for real-time and nested PCR. The normality of the data was verified by the Kolmogorov-Smirnov test. Continuous variables were expressed as median with interquartile range, categorical variables as frequency and percentage, and the Wilcoxon sign rank test was used to compare the IOP, the number of anti-glaucoma and antiviral medications at baseline with the final visit. The median age was 45 years, and there was a male preponderance. Majority of our patients had clear cornea. Iris atrophic changes were present in 32% patients. Majority of them had fine KPs, and most of them had a clear lens at presentation. When we compared the IOP and number of medications at baseline with final visit, the reduction in IOP was statistically significant, as well as the number of medications after treatment was statistically significant. PCR was able to detect a virus in 57.1% of the eyes. RT-PCR was done for all eyes except one, and nested PCR was done for 8 eyes. The most commonly detected virus was varicella zoster virus. This is a real-time report of a patient who was detected with HSV. This is the quantitative report of the same patient where we found around 1 lakh copies. This is the slit lamp photo of a patient where we can see the keratic precipitates due to varicella zoster virus. And following treatment, the KPs have resolved and the iris atrophic changes are visible. Similarly, we have a patient here with fine KPs due to herpes simplex virus, and following treatment, the KPs have resolved and the iris atrophic changes are noted. So as we all know, glaucoma is a well-known and dreaded complication of uveitis, and viruses pose a higher risk of developing secondary glaucoma. And PCR helps us to accurately detect the virus and start the required specific antiviral treatment. So in this study, VZV was the most commonly detected virus, which is also similar to other studies. And we did nested PCR for those cases where it was difficult to distinguish clinically between the viruses. We used acyclovir and valacyclovir for the management for acute cases as well as prophylaxis for recurrences. And specific antiviral treatment based on PCR is crucial to control IOP levels. In this study, we managed elevated IOP levels with a median number of 2 anti-glaucoma medications, which is similar to other studies. Our limitations are the small sample size. We will need a larger sample size to analyze the sensitivity and specificity of PCR. It's a retrospective study, and more studies including patients with or without secondary glaucoma are required so that we can find out the appropriate timing and duration of antiviral treatment necessary to control secondary glaucoma. Thank you.
It's a good paper.
Thank you.
So what was your protocol for treatment? What was the dose of oral, topical, and steroids that you didn't outline, what you treated them with?
Yes, sir. Topical steroids, Predfort we use, sir, from 8 and weekly tapering.
Okay.
And oral we started acyclovir, 400 to 800 mg.
How many
And
times a day?
5 times a day, sir.
How long is the duration of the oral?
For 3 to 4 weeks, sir.
Topical
And
antivirals?
Topical, no, sir.
No.
Topical steroids, cycloplegics, and oral antivirals.
And anti-glaucoma therapy?
And anti-glaucoma therapy.
Which were the
yes,
drugs
sir.
you used for anti-glaucoma? You didn't tell us.
Yes, sir. So we started with timolol, sir, or a carbonic anhydrase inhibitor. And
Avoided prostaglandins?
and avoided prostaglandins, yes, sir.
You said 3 to 4 weeks is for the therapy of antiviral.
Yes.
So your glaucoma, controlled or not, did not matter. You just stopped antiviral after 4 weeks. Is it that?
If required, ma'am, we continued it. Like most of our cases, when we treated them with antiviral treatment, we were able to bring down the IOP.
With medication?
So, yes, ma'am.
All right.
How
And
long was the anti-glaucoma treatment continued is what ma'am is asking.
Okay. We let them continue on the anti-glaucoma treatment for 3 to 4 months. We reviewed them regularly every 3 months. And if it was under control, we stopped. Otherwise, we call them for review after another month. And then we decided,
And were the glaucoma levels different based on the different type of antiviral?
No,
the
actually,
virals?
that difference we did not find, based, but that
It
would be
wasn't
interesting
statistically
to,
significant,
No,
they
it
were
was
all
not
practically the
statistically significant. Yes.
Did you give valcyclovir in few patients, or it was acyclovir in all the patients in your cases?
Mostly acyclovir. Few patients we've given valcyclovir.
Did you find any
also.
difference between the two? If you given acyclovir to some group and valcyclovir, any kind of difference in the response?
not
as such, no?
statistically significant,
Only except
at
the
least.
patient was a little comfortable with valcyclovir
Yes,
dosing,
ma'am.
right?
Yeah.
Okay.
So you stopped the antiviral when all clinical signs subsided.
Yes, and we
Was
repeated
based
the AC tap actually.
Then you did the PCR.
Then, yes.
So what
so
was
if
the
it-
costing to the patient?
Yeah. PCR cost, testing cost, sir is asking.
Because that would be borne by patient or your institute did bear it.
Yeah, the institute usually bears it for some of our patients if they need help,
But what
but
is the generalized cost? Because that is a costing to the patient.
Yeah.
Repeated PCR.
yes, sir.
Did you correlate a systemic or we do IgG, IgM in these patients of varicella zoster and herpes.
Yes,
Did
sir.
you do that also in these patients so then you could preclude an
The blood
invasive
serum
blood
test,
levels?
No, sir. Blood serum test
Yeah.
we didn't do for everybody.
Okay. Because even that can reflect infection in the eye. So
yes,
that
sir.
would be less invasive rather than doing an AC tap.
And a few of your patients were bilateral. So did you do tap from both the eyes separately, or it was just one eye?
No, we took only
Any eye.
one eye and the one which was at.
I think costing wise will also make a difference if we go
yes.
for
To both eyes, yeah,
exactly for rather invasive and as well as costing would be
Cost.
less.
Thank you so much.
Okay,
Thank you.
thank you.
Thank you.
Nice paper. Thank you.
You can call the next.
Next we have Dr. Devesh presenting ultra-wide-field angiography-based prediction of proliferative retinopathy in retinal vasculitis.
Thank you. Good morning, everyone. So I have no financial disclosures to make. Slide is not moving. Okay. So laser photocoagulation is the primary treatment for managing neovascularization in retinal vasculitis, and it may help prevent neovascularization in high-risk cases as well. Ultra-wide field angiography plays a crucial role in deciding the and guiding the treatment in such patients. However, risk stratification studies in retinal vasculitis are very limited, and they focus on capillary non-perfusion area, extent, and location measurement. Out of the two studies, this is the first study that is there published in 2017, where Sharif et al. They measured the capillary non-perfusion area as percentage of the total image area in pixels using the manual measurement function in image J, and they found that the ischemia, which is covering more than equal to 2 quadrants, is a significant risk factor for neovascularization. However, there are concerns with this model of CNP measurement, that there is peripheral image distortion that happens in ultra-wide field imaging, and so the area measurement will be inaccurate in the periphery. And there will be factors which will affect the total amount of interpretable fundus because of blurring in the periphery as well as eyelash artifacts. Now, another study in 2019, it divided the fundus into 3 zones. Zone 1 including the posterior pole, then zone 2 between posterior pole and equator, and zone 3 anterior to equator, and they found that presence of posterior pole disease is a significant risk factor for development of neovascularization. However, the concerns in this study are there are no cardinal points that are described for zone 1, zone 2, zone 3. There is no differentiation between neovascularization at disc and elsewhere, and there is no correlation that is made with disc disease activity. The aim of this study was to determine the association between ultra-wide field features and development of neovascularization in eyes with retinal vasculitis and suggest a simple, reliable, and practical approach. It was an ambidextrous study performed at the Retinal Lab and Vasculitis Clinic at RP Center over a period of 2 years, wherein ultra-wide field imaging and clinical data of patients were assessed. The inclusion criteria included good quality ultra-wide field angiograms of retinal vasculitis patient and available clinical data. Exclusion criteria being poor quality of angiograms, media opacity that did not allow assessment of CNP or vascular leakage, predominant uveitis being intermediate posterior panuveitis, and missing clinical data. Assessment of angiogram was performed on Optos by an experienced specialist. The grading of CNP was performed based on the preliminary data that we obtained from the retrospective patients. We divided the fundus into 3 zones. Central zone 1 of 6 mm radius. These annotations were done on the Optos software. The central zone of 6 mm radius, mid-peripheral zone of 6 to 15 mm, and peripheral zone beyond 15 mm radius. Now, dynamic use of all the images in the phase were used to cover all the quadrants thoroughly, and then clockers in zone 1, zone 2, zone 3 were identified. Leakage was categorized as no leakage, mild leakage, and profound leakage, both for perivascular leakage or capillary leakage and disc leakage. The outcome measures were systemic features and treatment parameters, then features of vasculitis, coexistent features, and angiographic parameters. Logistic regression was performed to identify predictors of neovascularization. Ultra-wide field images of 396 patients were reviewed. However, only 171 images of 171 eyes of 117 patients were found suitable for angiographic analysis. The median age of these patients were 28 years, predominantly males and predominantly bilateral disease. Some had systemic illness at the time of assessment and were on systemic treatment, anti-inflammatory treatment as well. Active vasculitis was present in 40% of the patients with predominantly venular. Proliferative disease was present in 54.4% of the eyes. Now, when we did the univariate analysis, the significant factors were state of vasculitis, type of vessel involvement, disc leakage, and perivascular leakage. In analyzing the capillary non-perfusion area clockers, we found that was also a significant risk factor, higher in eyes in which neovascularization was present. Now, odds of neovascularization at disc, if we see, if the capillary non-perfusion in zone 1 was more than equal to 3 clocker, it was 10-folds. And if we see neovascularization elsewhere, then capillary non-perfusion area, if it was more than or equal to 3 clockers in zone 2, then it was nearly 5-fold. On doing the stepwise multivariable logistic regression, we found that independent factors that were for neovascularization at disc was zone 1 capillary non-perfusion clockers. For NV, it was zone 2 capillary non-perfusion as well as disc leakage. However, disc leakage was found to reduce the odds of NV. Now, we calculated the area under curve for these 3 models, and the area under curve for all these 3 models were more than 0.8, that is good. And for neovascularization, any neovascularization, it was 0.8, that is high. So this study showed that zone and amount of capillary non-perfusion and angiographic leakage were found to be independent predictive factors for neovascularization in retinal vasculitis. So zone 1 capillary non-perfusion, it increased the odds of NVD development. Practically, if we see it, this is the area which is involving the posterior pole, and capillary non-perfusion in zone 2, that is between the posterior pole and equator, it affected the odds of NV. That is practically, if we see, it is the mid-periphery. And the isolated CNP in zone 3 did not affect the odds of neovascularization. Now, angiographic leakage, we saw that it did not affect the odds of NVD, but it did affect the odds of NV. Now, limitation of the study is that it's a cross-sectional, predominantly a cross-sectional, and need larger
Your time
cohort
is
studies.
up, huh? Try to wind up.
Yes. To conclude, this study offers a simple, practical, and reliable approach without distortion-related inaccuracies which are there in the existing models of CNP area assessment. And prophylactic laser could be applied based on ischemic zone involvement and disease activity to prevent complication in these patients. Thank you. These are my references.
What were these cases of these vasculitis?
These
What was
were
the
predominantly
etiology?
vasculitis.
No,
And
etiologically, I'm
so
saying.
majority of them were idiopathic. Systemic disease was present in only 15 of the eyes out of 15 of the patients out of 100.
So what was the systemic disease I'm asking?
Systemic diseases, 5 patients had tuberculosis, 3
Okay.
had pulmonary, and 2 had lymphadenitis. 1 patient had psoriasis, then 1 had SLE, 2 had Behçet's. So I had mentioned that
Yeah,
in
yeah.
one of the slides.
One thing, it's a nice study, but it would have made much sense had you really talked about the predictive value. That means instead of cross-sectional, it should be a prospective study, and
So
then you comment that again is a better thing because
Limitation
you are
I mentioned
predicting.
that
Yeah.
So out of the 117 patients, 83 patients I had mentioned that 83 patients were retrospectively included and 34 patients are prospectively included, and now we are following those patients to actually see what is the relative risk. Now I have presented the odds, but relative risk we need obviously a larger cohort.
So you treated them with laser, all of them? Or with
Those patients who had neovascularization, they were later on treated with laser, but that was not part of the study.
anti-VEGF? No, I'm just asking you what you treated with. Since you're doing this, so finally the treatment is what is going to get
Yes.
affected, no?
So we did not.
So what was the treatment you did for NVE and NVD? Like,
So for NVE and NVD, we did laser. For NVD, we routinely do a PRP, and for NV, we do a sectoral or scatter
sectoral laser. Any anti-VEGF was used
No,
in
we
any
are
of these
not
patients?
using anti-VEGF.
Okay.
For the study, as you've mentioned that if the CNP area is in the zone 3,
Zone 3. Yes.
there's not much of a odds to
So
develop,
anterior to
right?
the equator, it did
Yes,
not
so it's
affect the
only in
odds.
zone 1 and zone 2 if
Zone
you have
1 and zone
CNPs,
2.
it creates more of a positive production for us. So how do you justify your comment on ultra-wide field imaging base that's much better than compared to a conventional which we use?
So still ultrafide field will give us a view till the equator. And now this is a model in which we have used the zone 3 to calculate and see whether it helps or not. So if it is zone 3 is not contributing to neovascularization, then we need a peripheral examination more anterior to the equator. So if we have an imaging system which is providing information about the posterior pole and mid periphery, then that is sufficient enough.
Yeah, that happens only in the conventional angiography also. I'm saying how come you're going to justify the usage of ultra-wide field imaging
So
if it is compared to
conventional
the
also there will be a montage
Yeah.
creation, and the area calculation is very difficult with montage. And you have artifacts with montage, so ultrawide field will provide you a single image in which you can
artifact
measure
would
it.
be less in this. Yeah.
But I think comparative study would be the exact
Much
answer
better.
for this.
Yeah. Because again,
It's-
we've
it
come
was a
back to
comparative
costing.
study.
Yeah.
It was
True.
a comparative study, but a cohort study will be.
Absolutely, absolutely.
Nice. Thank you.
Thank you.
Yeah. Now I call upon the next speaker, Dr. Eliza Anthony. Yeah. Acha, okay. Dr. P. Savitri. And she'll be talking on atypical manifestations of ocular toxoplasmosis, a diagnostic and therapeutic challenge.
Good morning, one and all present here. My topic for today is an atypical manifestation of ocular toxoplasmosis, a diagnostic and a therapeutic challenge. Its cursor is not moving. Ocular toxoplasmosis is one of the most common cause of infective posterior uveitis worldwide, and these are all the atypical forms we know. And the exact estimation of the incidence of them is not known or underestimated because of unaware of the atypical forms, is because it's a clinical diagnosis. Toxoserum IgG or IgM is not done, and PCR is not feasible in these cases. Most of the time, it's often diagnosed as idiopathic because the other eye findings are not highlighted or overlooked. The diagnosis of atypical toxo is highly significant to avoid the recurrence and sight-threatening complication. Our study is a retrospective study in which patients who had atypical lesions who were tested positive for either IgG or IgM serum antibodies who showed positive response to antitoxo medication, that is standard triple therapy was given for all immunocompetent patient, and intravitreal clindamycin was given for an immunocompromised patient. Improvement in the disease activity or an increase in the best corrected visual acuity has been recorded. And comprehensive history, visual acuity, and anterior segment, posterior segment, and multimodal imaging were done whenever necessary. A total of 15 eyes of 12 patients who met the inclusion criteria were diagnosed with atypical toxoplasmosis. Our study has a male preponderance with the age range from 21 to 66 years. The BCVA ranged from 5/60 to 6/6. Majority of the cases were neuroretinitis, which had 26.67%, followed by posterior scleritis, exudative RD, vasculitis, multifocal toxoplasmosis. Majority of our patients were immunocompetent in our study. An IgG ranged from 3 to 650 international units. Our first case is a 47-year-old female who presented with vitritis, disc edema, and subretinal fluid at the macula. Patient was already treated elsewhere with oral and topical steroids, and she had come with the recurrence. Other eye examination showed a CRA patch at the infratemporal quadrant. An atypical toxo was suspected and started on antitoxo medication. Our second case was a 53-year-old female who presented with vitritis and disc edema. This patient was 3 months post-op, treated as a recurrent post-op uveitis, and the vitritis was increasing with the fluid collection in the subtenon space. And patient was treated with antitoxo medication for 6 weeks, and post-treatment, visual acuity improved to 6/9. And the next patient was a 47-year-old male who had a multifocal retinitis patch between the arcades with an arthritis below. And other eye showed a multiple CRA patches. So in this, the patient vitritis was very less, so we suspected an immunocompromised state, and it was positive. Patient was a HIV positive, and intravitreal clindamycin was given weekly once, and then along with the heart therapy in the general hospital. And this is another case where he was a 45-year-old male who presented with uveal effusion syndrome, where patient had an exudative retinal detachment. Along with triple therapy was started, along with sclerostomy was done for this patient. This is a 45-year-old male who presented with scleritis in both eye. When we take a close look at the fundus, there was a perifoveal speck of whitening seen in the macular area. OCT showed PAM with an ellipsoid disruption of the ellipsoid zone suggestive of a drifter. Patient was, his IgG toxo was 450, and he was treated with antitoxo medication, and review awaited. And this is a 33-year-old male who presented with multiple whitish creamy lesions suggestive of APMPPE. He had contact with pets, and his other eye had an CRA patch at the infratemporal quadrant. Though APMPPE is a self-limiting disorder, to avoid recurrence in this case, patient was started on antitoxo medication, and the patient is post 6 weeks, patient vision is 6/6. Until now, there was no recurrence. To conclude, the diagnosis of atypical toxoplasmosis can be made with a high index of suspicion. A typical or an atypical ocular presentation, response to antitoxo medication, positive IgG or IgM serum antibodies, history of contact with pets, and positive PCR results from aqueous or vitreous humor. Any of the 3 criteria in this 5, we would call it as an presumed ocular toxoplasmosis. And our study highlights several atypical clinical manifestation of ocular toxoplasmosis. Also reveals the presence of rare conditions like PAM and drifter. While atypical presentations are often seen in immunocompromised individual, our finding shows the immunocompetent patients can also have these atypical forms. Given the varied clinical presentation and challenges in confirming a definitive diagnosis, we propose a set of criteria for presumed ocular toxoplasmosis that can aid in identifying the condition in the absence of definitive PCR result. This approach will help guide us to appropriate treatment, improving the outcome for affected patients, and to avoid decrease the incidence of idiopathic uveitis. These are my references. Thank you.
Thank you. I think very good presentation, but I think you had us confused, we always think like it's retinochoroiditis. Many patients had just deep choroidal lesions, and just depending on the scar on the other eye, you were treating them.
These are atypical forms, sir. The rare atypical forms which we found in our series.
And which were the patients? Why were you injecting your patients who are immunocompromised and not your immunocompetent patients? Like, why is the reason you inject only that subset?
No, immunocompromised patients, we can't start them on the triple therapy because the steroids we have. So we prefer to inject intravitreal clindamycin. The other patient, they responded well with the oral treatment only, sir. So we didn't.
What is your oral therapy? What is your
The standard triple therapy of trimethoprim sulfamethoxazole with oral steroids, 1 milligram per kg.
There are no side effects of these, no side effects of oral therapy because we prefer to give intravitreal in most of our cases. So,
Ma'am, so far we didn't find
all right.
any
And how frequently do you repeat your intravitreal?
1 week.
1 week,
week.
for how long? Till the time you see the activity?
Yes, activity response.
So usually it's how many weeks is what I want to know.
Usually
In
one,
average patients, 1 month.
3 weeks we have given for that immunocompromised patients, sir, along with the heart therapy.
So one every week you are giving.
Every week.
you're
Depending upon the response we give it.
giving. Yeah, because as Maran was saying, systemically most patients, if you start them on clindamycin, they develop a pseudomembranous type of colitis and diarrhea. Because quite a
sir,
few of my
we-
patients do develop.
No, we didn't give systemic clindamycin. We gave intravitreal clindamycin.
So systemic therapy was only
Only
this.
triple therapy.
Only triple therapy.
Yes, sir.
So your take-home message is that 5 criteria. If
Yes,
a
sir.
person fits into those 3 criteria,
Yes.
then it's a case of
Presume ocular
because the
toxoplasmosis.
presentations were too varied,
Hmm.
starting from deep choroiditis to vasculitis.
Yes, sir.
So which are quite rare.
Yes.
So nice presentation.
Thank you, sir.
What is your triple therapy? You said one was sulfa with trimethoprim, then steroids.
Double strength.
Yeah, Septran DS.
Septran DS, and then oral steroids with azithromycin.
With azithromycin you're using.
Azithromycin,
You're
yes.
using azithromycin.
Yes.
What is the dose of azithromycin you're
Initially
using?
starting 3 days we give 500 mg OD.
Yeah,
Later
just
for
sit. Yeah, they can also listen.
starting 500 mg OD for a week we'll give. Later for 6 weeks 250 mg.
Okay.
OD.
Fine. Good. Thank you so
Thank
much.
you.
Thank you.
Thank
Thank you.
I call upon Dr. Anoop for his next presentation. That's on choroidal neovascular membranes associated with toxoplasma retinitis.
A very good morning to the panel. I have a liking for toxoplasma retinitis and like to speak on that. The second thing that was in this particular presentation was few cases of toxoplasma retinitis which are active retinitis get confused for a recurrence, which is a CNVM. That was what was my study here. So the purpose of the study was to see the imaging characteristics and treatment outcomes of the choroidal neovascular membranes associated with toxoplasma retinochoroiditis. The design was this study was essentially retrospective, and the cases of toxoplasma retinitis which developed CNVM either at the baseline or during the follow-up were included. We did a fundus photo and OCT documentation of them. Exclusion criteria involved negative toxoplasma IgG, and a minimum follow-up of duration of 6 months was considered for the study. Imaging characteristics which were various were analyzed. The key results and findings in this were, and for me this was one of the interesting things, that within a 10-year period of 2014 to 2024, seeing these 248 cases in Bhubaneswar, we saw it was only 6% of cases that developed CNVM. So this disease was rare. This complication was rare. The second key takeaway was the mean age of patients for which presented as CNVM was 19 years of age. We have another 2 series where we published on IgG avidity and on the treatment that we use for toxoplasma, and this particular age group of CNVMs was a decade or decade and a half younger than those 2 series which were from the same place. The presentation patterns, we noted 4 distinct presentation patterns. One was active retinitis with early CNVM. The second was resolving retinitis with late CNVM. The third was healed retinitis, but the CNVM is active. And the fourth was healed retinitis and scarred CNVM. So these were the 4 groups. And amongst the types of the CNVMs, we saw that 10 were classic, 2 were RAP lesions, and all of these lesions were adjacent to the retinitis lesion. Uh, of the 4 groups that I was speaking earlier, the first group we found out a CNVM occurring within 6 weeks of presentation as toxoplasma retinitis. This was said to be the group A. The group B was when the retinitis was starting to resolve, it was partially active, and the CNVM happened later after the 6 weeks. The third group was healed retinitis and active CNVM happening somewhere between 3 to 6 months. And the fourth was healed retinitis, healed scarred CNVM. Now, why is this significant? I would like to show you 2 cases. We see a central scar of toxoplasma retinochoroiditis. We treated it earlier 6 months back with an active toxo regimen. We see a speck of heme, and this was one of the very common findings that we noted in our case series. With a grayish area which an OCTA shows to have a twig of CNVM. Another case, now the color is of lot of importance here. We see a yellowish color necrotizing full thickness retinitis, which shows a central hypo surrounding hyper, a very characteristic of retinitis, while the CNVM part of it, seen as an early twig on the FFA and seen a leakage, helps differentiate in the active disease. We treated this with injections. We used a total of 24 injections in the study with 2.18 injections per eye. In conclusion, the toxoplasma retinitis that we saw leading to CNVM was rare. It happened in only 6% of our patients. The second thing was it was always near the scar. The third thing was that we required lesser number of injections and age-related macular degeneration, and identification of them was essential to differentiate from active retinitis recurrence versus a CNVM per se. Thank you.
Yeah, I think it's a very good study because we have also seen this I have seen a few cases in the pre-VEGF era. I had a young 8-year-old child with a toxoplasmosis macular choroiditis who developed a CNVM, and that was the time of PDT.
Yeah.
And he responded with a single shot of PDT that time, So I think these inflammatory CNVMs respond very well to minimum intervention, as you rightly said, because they are not as active as our other types of myopic or age-related CNVMs. I think it's and you have to pick that up, because sometimes you feel that it's the recurrence of the infection, whereas it's a CNVM which is hiding in the infection.
And what is your take on whether to be in plain anti-VEGF or a combination therapy? What do you prefer
So
in
for
such
the
cases?
active retinitis, we did give a combination of intravitreal Clinda, DECA, and either a bevacizumab or ranibizumab. But for the lesions where retinitis was inactive, we just went forward with anti-VEGF.
But did you try without anti-VEGF in any? Like if we just give intravitreal Clinda with steroids, I feel still these are inflammatory membranes should resolve. This is what my take is. I don't know.
Okay, I don't think this was retrospective
You didn't wait,
series,
you just
though.
injected
we did
3
inject.
together.
Yeah, we did.
A systemic treatment was given for toxo or what?
So for the active cases, they were on toxoplasma treatment. The treatment that we gave was Bactrim DS for 6 weeks. We do it with steroids, and whenever the macula is involved, the disc is involved in first order vessels with an intravitreal Clinda DECA.
Okay, so you've loaded with the systemic as well as for intravitreal
Yes.
in the acute cases.
Do you think that OCT can guide us better about CNVM with toxo?
Yes, of course. I think one of the differentiation that we noted in our case was the scars of toxo are thinner necrotic, while the CNVM will be thicker. It will have a subretinal hyperreflective membrane. It will have a fibrotic scar if the CNVM is scarred. It will have a double layer sign, heterogeneous reflectivity within, and unmixable would be the intraretinal cystic spaces and the fluid, which is not generally seen in toxo. You might get a small neurosensory detachment, but not many intraretinal fluid pockets.
Thank you.
So for follow-up cases, sorry.
No.
For the follow-up, we would prefer to have FFA over OCT. You're going to follow the
we
patients,
did with
or
an OCT actually.
okay, you follow with OCT. Okay.
No, I think the simplest take-home message which you highlighted very beautifully was if you see any intraretinal hemorrhage in these patients of toxo, you have to suspect a RAP lesion. So typically an intraretinal hemorrhage will be reflecting a RAP lesion rather than a type 2 CNVM. Thank you so much. Thanks.
Thank you.
Next speaker is Dr. Sandhya Harwadkar. She will be speaking on presumed intraocular tuberculosis, clinical presentations and outcomes.
morning, one and all. Can I start? Good morning, one and all. I'm Dr. Sandhya Dharwadkar from Mysore Medical College. As we all know,
Ma'am, can you be a little louder, please? I think the voice is...
दूसरा वाला भी चालू करो.
My time is going. Ocular tuberculosis includes the entire spectrum of clinical presentations caused by the Mycobacterium tubercle bacilli, either by direct invasion of the eye or as a immune-mediated inflammation in response to its antigens. The intraocular disease is very difficult to get confirmation directly, and hence we term it as presumed. Since the first proven case in 1883, where the bacilli was identified, till the present era, our understanding of this disease has evolved tremendously. We have better guidelines, we have better treatment modalities and diagnostic tests. Keeping this in mind, we took up this study, which was a retrospective observational case series at a single center, during which we had 10 consecutive cases which we identified and followed up for a period of a year. We had patients from 20 to 45 years of age with equal gender predisposition and equal laterality. The vision acuity presented from about 6/12 to PL positive cases. The anatomical involvement in our patients were about 40% presenting with panuveitis, another 40% having choroidal granulomas, while just one case of occlusive vasculitis and multifocal choroiditis. A few of the cases I'll show. A single choroidal granuloma presenting in a 22-year-old male, the OCT showing the typical choroidal elevation with subfoveal fluid, treated with ATT alone and good resolution to 6/6 in a month or two. This is another granuloma, but lying along the optic nerve, presenting with PL positive vision. This patient was Manto positive, gave history of contact, and was treated with IVMP along with the ATT. She continued only the ATT for about 6 months. The vision improved to 6/24. This was a case of occlusive vasculitis, unilateral involvement with pipe stem sheathing and multiple hemorrhages, multifocal involvement, who was Manto positive. Other cases with anterior broad-based synechiae showing anteruveitis. A 35-year-old female having bilateral panuveitis-like picture. She was Manto negative, quantiferon TB negative, but the HRCT picked up features of old COX. She was treated with both oral steroids first along with ATT, but did not tolerate the oral steroids. Hence, she was treated with injection of posterior subtenon and Skinacort. Over a period of time, with immunosuppressives were continued, and she improved to 6/12 with good resolution after 3 months. This was the most difficult case that we had. A 27-year-old female with one eye choroidal granuloma, resolved very well after 6 months of ATT and oral steroids. For 6 months, she was fine, and then she developed a multifocal relapse. Because of this, she was again given ATT along with immunosuppressive therapy. Still, over a period of time, she still worsened and had severe vitritis, which had to be treated with a vitrectomy. After that, the immunosuppressive therapy was continued and 9 months of ATT was given. We suspected it to be a multi-drug resistant tuberculosis. She stabilized after a period of 1.5 to 2 years, and this was her final picture with a 6/60 vision. The outcomes in our patients' vision improved in most of the cases from 6/6 to 6/60, and the disease activity stabilized with multimodal treatment. The residual vision loss was noted to be either because of cataract or a scar at the macula. The recurrence was noted in only one of the cases. All the tuberculoma patients resolved with ATT alone. To discuss, India still has a very high endemicity of tuberculosis. The risk factors further increase because of the population, crowded, unhygienic conditions, either the improper use of ATT causing drug resistance, and the emergence of HIV positive cases. The varied manifestations allow for the delay in the diagnosis sometimes, and the management also is not as structured. But nowadays, thanks to the guidelines given by the COTS study and the COTS calculator, which is available online, it has allowed for much better treatment outcomes. So for our patients, we have a checklist where we have a history of contact with the tuberculosis case. We rule out mimickers, especially ocular syphilis, sarcoidosis, and sometimes viral cases. The diagnostic test, we try to include all 3 of them. We take a pulmonology opinion if we have features of pulmonary positivity on HRCT, and then the treatment is tailored based on the COTS guidelines. To conclude, presumed intraocular tuberculosis is like a parody of maladies with every presentation possible, and the outcomes can be improved with timely diagnosis, early and appropriate treatment, especially the immunological therapy. Thank you.
Very nice. Yeah.
Yeah, thank
I'll
you.
have a few questions. I think it's a very gray zone when we talk about the discussions regarding the diagnosis for intraocular tuberculosis. If there is a tuberculoma, it's fine because it's a straightforward case, you can start with treatment. When we talk about the diagnostics, do you believe only Montux, what should be the cutoff value for you? And when you talk about the three diagnostics to be taken together, what is your take that what should be the, the cutoff value for us to diagnose that?
Yeah, thank you. We try to get all the three tests for each of the patients where we are suspecting ocular tuberculosis and include it as a part of the COTS calculator, wherein we have the MAN2, the quantiferon TB gold and the HRCT. Very rarely we have patients who cannot afford and we avoid the quantiferon TB gold, where the patient has a typical tuberculosis feature or has a recurrence. We try to start off with anti-tubercular treatment as well, along with the oral steroids or immunosuppressives.
If
So
you
the
have
COTS
any
calculator guidelines accordingly, we usually use a median 4 or an interquartile range of 3. We start off with the ATT
If
cover.
you come across any case where you don't have any tuberculoma seen on the fundus evaluation and all the three tests they come out to be negative, how would you take up such case? Would you start the treatment or how will you take?
If the tests are negative and there is no posterior involvement, then we don't start the ATT.
The patient has vasculitis, but you don't see a typical tuberculoma.
Vasculitis, I would not suggest just ATT only for vasculitis. If it's an idiopathic vasculitis is much more common. We don't start if we don't have any other tests negative or positive.
Do you believe in starting a trial of ATT if you have a positive history
No.
of contact in the patient?
Positive history of contact has to be a very much high risk, as in a family member wherein has had pulmonary tuberculosis and a positive sputum. We try take a pulmonology opinion, a bronchoalveolar lavage if required, along with an HRCT test. So other than that, we don't start ATT. We give the options to the patient, but we try to avoid if it is not showing a positivity on either of them, MAN2 at least 10 millimeters.
Maybe I believe if the patient is not responding to treatment as is required as we think it should be, and we have a strong positive Montus because it's very dicey, it may go
Agree.
Anywhere
way, yeah,
in
either
Indian subcontinent. So I usually prefer to have a trial because ATT being quite a safe. So usually they respond tremendously, very nicely if they are suffering from their tuberculosis.
Actually, the microbiology student whom I showed, the difficult case, who presented with a granuloma, she was MAN2's negative, quantiferon TB gold negative, HRCT, MRI brain, ultrasound abdomen. We couldn't find anything. I wanted to start ATT because I know the typical picture.
Yeah.
And still I gave her ATT
Yes,
along with oral steroids. It recovered completely in 6 months. Another
So I
6
think
months
trial
later.
won't harm the
Yeah,
patient
but
for a
that is
month.
considered like a typical tuberculosis in the eye. So there are some features like these which can be started on ATT based on the clinical picture alone. But I think anterior-uveitis and vasculitis are something which we need to take it with a pinch of salt.
Absolutely.
Dr. Sandhya, one question. Very nice cases, everything good. I differ in one aspect. You said that I gave ATT for 6 months. I think we give ATT for 12 to 15 months. 6
Okay.
months, they're bound to recur, like you saw recurrence in
One
your
of them,
case.
yes.
So
We still follow a period of 6 months for most of them, ma'am. And sadly, we have patients presenting with ethambutol toxicity at the end of 4 months because of the high dose
no, but
nowadays.
we, for our ophthalmic patients, we follow the same regime. After 2 months, I think we stop
Another 4
ethambutol.
months. Huh.
We do stop in our patients. For
Okay,
ophthalmic,
okay.
the guidelines, they've changed. They
Yes,
say ophthalmic involvement will just stop ethambutol.
Okay, okay.
So then it
Fine.
works.
That's a
Just
nice
wanted to ask you
point for me.
Same as ma'am's. At least ATT should be for 12 to 15 months. Otherwise, the recurrence is bound to occur and we are creating MDD patients again.
Yes, sir, that would be
Now
one
there
of
is
the
a new
major.
regimen which abolishes ethambutol out of it and a new drug is added to the new
Linezolid?
They do it for
Linezolid? Okay.
But even linezolid has ocular toxicity. If you've
Can
seen it
have
causes
optic
optic neuropathy.
Yes.
So I have had a lot of patients with linezolid toxicity.
They also have.
Ethambutol has very good action against the tubercle
Yeah.
bacilli is
No,
what they
but
say.
we've
So
had
at least the initial 2
So
months.
many blind.
No,
First 2 months.
You know,
yeah.
the problem is the FDC. Because they are
Okay.
just giving the drug as per the FDC, which is freely available.
Which is
as per the
available in
weight.
dots. Yes.
You know, so as per the weight, if the patient little heavy, then the dose goes beyond the toxic
goes
dose.
much beyond the
Much
toxicity.
beyond.
Yes, sir, exactly.
Last question I had, sorry to bother you.
Not at
What
all.
about the role of intravitreal avastin in these patients with, recalcitrant granulomas,
So this female did have intravitreal anti-VEGF as well.
Okay,
But
that's what I wanted to know.
over a period of time, it just was a very temporary treatment. She didn't respond that well as expected. So vitrectomy did stabilize the disease completely.
Okay.
It removed the load, I think,
Right.
of the bacilli and allowed for a very good control.
Nice.
Yes, sir.
Thank you.
Thank you. We have not tried a vitreous biopsy yet, but the vitrectomy case, that vitreous sample was sent.
So it was positive?
No, it was not.
Okay.
We couldn't get a positivity at all. Thank you.
Thank you so much. Thank you. Yeah. So I think good discussion. I think we continue this same tuberculosis with Dr. Mayur Morikar. He's going to demystify further persisting and relapsing inflammation despite AKT in ocular tuberculosis. I think it's a continuation of this talk. Dr. Morikar, please.
Good morning, everyone, and greetings from Mumbai. And we are here to talk about persistent and relapsing inflammation despite AKT in ocular tuberculosis. We all know that the diagnosis and management of ocular tuberculosis poses a significant challenge despite the publication of standard treatment workflow from the ICMR. We are sometimes in situations where use of anti-tuberculosis treatment fails to stabilize the inflammation, and there are relapses which require immunomodulatory treatment, which may be conventional or biologics. And that exactly is the aim of the study, with an emphasis on assessing the role of Mantoux test grading and time to intervention with AKT since the diagnosis of ocular inflammation in predicting the requirement of immunomodulatory treatment post-AKT. In a retrospective study, which was initially planned for about a year, but then we extended it to about 3.5 years or more at our institute, where all patients were treated as per standard guidelines published by the ICMR. The Mantoux test was graded as strongly positive if induration was about 20 millimeter, or if there was a blister formation or ulceration accompanying the induration. And the time to intervention with AKT was considered delayed if AKT had been introduced 6 months after the initial diagnosis of ocular inflammation by the primary treating ophthalmologist. This is a summary of the results. The first year we had 34 patients, but when we extended it, we had a total of 103 patients, of which 14 were returned back to the primary institute because they went back to their place of stay, and 89 were the patients who continued their follow-up with our institute. This is the spectrum of involvement of the various organs of the eye. This is a diagnostic workflow sheet. You see that of the 89 patients, 82 had Mantoux test, of which it was positive in 65 patients, and a CECT was done in 78 patients, in which it was positive in 70 patients. This is the treatment summary. You can see that all the patients were treated with AKT, and AKT plus immunomodulatory treatment was included in 28 plus 1 patient who received topical immunomodulators. So we come back here to the summary of the results. We are starting off with 89 patients. Persistent or relapsing inflammation requiring immunomodulation was present in 29 of the 89 patients. It includes the 30 of the 34. So you see it's about 1/3 in 1 year, and it's about 1/3 in 3 years as well. This is the breakup. You see that methotrexate is the most commonly used agent. It is used in combination with other agents as well. And in 2 patients, we had to resort to use of tofacitinib. Calculating the odds of requirement of IMT, when we see Mantoux strongly positive, delayed introduction of AKT, the odds are higher when both of these are present. But when these are combined, you see the results. 30 patients with a strongly positive Mantoux test, 20 of these had an additional delayed intervention with AKT, and 13 of these 20 patients required use of immunomodulatory treatment. Complications of IMT because of AKT, resurgence of tuberculosis not seen in any patients, as is in sync with other literature. Points to ponder: persistent or relapsing inflammation noted at times despite AKT in ocular tuberculosis. Adequate and appropriate use of immunomodulatory therapy resorted to at such times. Strongly positive Mantoux test and delayed intervention with AKT increases the odds of requirement of immunomodulation post AKT. But probably the most important point to ponder over is that 20 of the 30 patients in this series had a delayed introduction of AKT despite having a strongly positive Mantoux test and despite having additional supportive systemic radiological evidence of tuberculosis. And 13 of these 20 ultimately ended up requiring immunomodulation. And this makes it important to dissipate knowledge of the clinical phenotypes of ocular tuberculosis, which is all important for the diagnosis of ocular tuberculosis. Limitations of the study obviously related to a single center personal bias. There are other factors also. And finally, the conclusion remains the same as the points to ponder. persistent inflammation may require immunomodulation, which may be considered safe if given under the watchful eyes of primary physicians or chest specialists. Thank you.
Thank you, Mayur. I think it was a very interesting caveat which you brought out. So the patients who received delayed AKT developed more of, like you're trying to say.
Yeah, are more likely to develop such an inflammation which will require immunomodulation.
So what is your hypothesis for that? Like, why would you say that is happening in these patients?
I think that's related to the fact that then you will have the nidus for the inflammation which will persist for a longer time. If you intervene with AKT early enough, then you are treating the organism there. So it's something like an infection getting converted into something like an
chronic.
My question is why it was started delayed when they were already suspected to be.
Yeah, so that's what I'm trying to bring out.
Yeah.
These are all patients which have been referred to our institute. So it's taken time.
Okay.
Patients have received treatment, not got better, then referred to us.
So diagnosis was delayed actually by the time they reached you.
diagnosis was
Okay.
delayed.
Okay.
Do you think a subset of Do you think there's a subset of these patients which not necessarily will be requiring immunomodulation, but as Madam presented in one of her cases, could be a resistant?
Yeah, so I was waiting for that question to come from you. So in all these patients, see what the chest physician is doing is, you notice all of them have undergone contrast enhanced chest CT. So whenever possible, we do a EBUS, biopsy, and then you have the organism, and then you already have tested for the.
Great.
So we haven't used this in any of those patients who had MDR.
But that will happen only if the patient is having pulmonary cox. What about the rest areas?
So in the rest areas, then so what we are doing lately is that we are actually recommending a PET CT to screen the entire body and see if there is any other place.
Right.
Very good. Very.
Thank you.
Thank you.
Next, Dr. Archita Sharma for structural and electrophysiological correlation in tubercular serpiginous like choroiditis.
Good morning, everyone. So the study I did under the moderation of Dr. Anup Kelgaonkar is on the structural and electrophysiological correlation in tubercular serpiginous like choroiditis. So serpiginous like choroiditis, as we know, is a multifocal inflammatory choroiditis associated with Mycobacterium TB. Multimodal imaging in SLC, it basically enhances the diagnostic accuracy. It aids in disease monitoring and it guides the treatment strategies. So OCT and OCTA can be done to know the structural changes of the disease and the choroidal blood flow. Fundus autofluorescence will help us know the metabolic activity and the damage of the RPE. And the electrophysiological tests like the full field and the multifocal ERG, they will help us in evaluating the global and the localized retinal function. So why we wanted to do this study was because anatomical recovery versus the functional recovery is not very well studied in the infective or the inflammatory conditions, and we wanted to explore that further. We wanted to explore the complementary roles of the multimodal imaging and multifocal ERG to combine the structural and functional assessment for precise diagnosis, monitoring, and management, and to highlight the multifocal ERG potential in the early detection, localized functional impairment as an adjunct to the imaging techniques. So we did retrospective analysis of eyes treated for SLC. We included the eyes which had completed 6 months of ATT and had a good visual outcome at 6 months of 20, 40 or better. We excluded any patient that had inadequate follow-up or the documentation was missing. So we had analyzed 17 eyes with a mean age of 33 years. Visual acuity in most of the cases had improved from a mean of 0.7 logMAR at baseline to 0.2 post-treatment. And what we found in the electrophysiological studies was in full field ERG, in 7 cases, both the photopic and scotopic response was reduced. In 5 cases, only the photopic response was reduced, and in 5 cases, again, we had a normal full field ERG. But in multifocal ERG, we had a globally reduced amplitude with certain localized areas of low amplitude, which I'll be explaining further. So this shows the 5 cases in which we saw that only the photopic phase was reduced and the scotopic was normal. And for them, we could hypothesize that most of the patients that had an involvement of the macula only or the posterior pole had mostly a reduced wave amplitude of photopic phase, but a normal scotopic phase. And in all these cases, in multifocal ERG, the wave amplitude was reduced. In another 7 cases, both the photopic and scotopic phase was reduced, the amplitude in both of them. And again, multifocal ERG was reduced. And in one case, there was increase in the implicit time on full field ERG. But again, on multifocal ERG, we had a reduced wave amplitude. And when we further studied these multifocal ERG, what we found that was when we did a quadrant analysis for the fundus photos and the ERG findings, multifocal ERG, we could see that the wave amplitudes were reduced more in the areas which had an outer retinal involvement. Like in this fundus photo, the above one, we can see whole of the posterior pole is involved. And hence in multifocal ERG, all the waveforms had a reduced amplitude. Whereas in the lower photo, we can see that predominantly the superior temporal and the inferior temporal quadrant was involved. And when we did a comparison to the multifocal ERG, which is a visual field test that we have, in this interpretation, we can see that in the inferior nasal and the superior nasal quadrant, the waveforms were reduced, and that was corresponding to the area where the outer retinal involvement was more. So to conclude, structural changes in the outer retina, it strongly correlates with electrophysiological abnormalities in SLC. Multifocal ERG, it serves as a useful adjunct to multifocal imaging for detecting the functional impairments not apparent through the standard visual acuity tests. Despite the clinical resolution and a good visual acuity, there can be a residual functional deficit that can be present and that can hamper the quality of vision. Multimodal imaging, it plays a crucial role in diagnosis, monitoring, and managing SLC effectively. And the integration of electrophysiological testing with the imaging techniques, it will improve the disease understanding and will help us in bettering the patient care strategies. Thank you.
Yeah, I think good. Actually, we don't. At least I don't understand much of ERGs, so I won't speak on that. But I was thinking, why not a perimetry would be a good option, no? You know what I mean to say? A perimetry is a cheaper, non-invasive, simple option which would give us a similar sort of a picture that where are the scotomatous areas. You could do a central 10-2 for the macula and a 30-2, you know. So that's one idea came to me.
We actually plan to do it as an extension for the study.
Yeah, you could do it, you know, as a comparative. Yes. That could give you a good idea.
So all the cases which were shown by you, they were quite, the diagnosis were clear from looking at the case. They were advanced cases. So we know that this part of the visual field is going to go. So what additional finding are we getting? Is it that patients were normal clinically and then we picked up the ERG subnormal? Is it that?
No, so all the patients had clinical findings. The fundus findings were there even on OCT and FF.
So what additional information will this give?
We just saw that basically first we thought maybe multifocal ERG shows a global reduction in the wave amplitude. But when we compare to certain fundus photos, then we saw in only the areas where the outer retina was affected, only those areas had an affection of the multifocal ERG and not global reduction was there.
Thanks. Yeah.
Thank you.
Thank you so much.
Next. I invite Dr. Shravya Chaudhary for the paper Late Diagnostic Revision to Tubercular Choroiditis in Patient with Recurrent APPM PPE.
Shravya.
Yeah, she has.
Hi. Good morning, everyone. So I'm Shravya Chaudhary Balla, Uveitis Fellow at LV Prasad Eye Institute, and I'll be presenting on late diagnostic revision to tubercular choroiditis in patients with recurrent AMP. So we all know that AMP is an inflammatory eye disease that affects the inner choroid and the outer retina. It has been first described by Professor Gass in 1968 as these multiple discrete creamy yellowed lesions that you're seeing in this fundus image. At that time, the primary pathology was thought to be at the level of the RP. And it was classified under the spectrum of white dot syndromes. But later on, it has been reclassified as choriocapillaritis. So the pathogenesis is not known. A pre-existing autoimmune and autoinflammatory disease are known. Positive TB immunological test has also been reported, and HLA-B7 and HLA-DR2 has also been reported. In addition, numerous cases have also shown that there is an immune-driven nature because post-immunization also AMP is known to occur. So with this, I move on to the study. The purpose of the study was to investigate recurrence patterns of AMP and its diagnostic revision to ocular tuberculosis. So we retrieved records from 2014 to 2024. We included all patients who were diagnosed as AMP and had at least a clinical examination of follow-up of 3 months. We excluded patients with incomplete medical records, and descriptive analysis was done. We used the Fisher extract test to see if there was any statistical significance. So the initial presentation, treatment and follow-up, recurrence, clinical phenotype of recurrence, investigations, treatment and follow-up were noted. A total of 40 patients met the inclusion criteria. The cohort had a mean of 33 plus or minus 9 years. And we saw that recurrence was noted in 18%, that is 7 patients. And these 5 patients were reclassified as ocular. If you look at this table, we can see that 5 patients were reclassified as choroidal granuloma, and 1 had serpiginous-like choroiditis based on the lesion morphology, along with laboratory test and a chest X-ray or X-ray wherever required. Out of the 7, 2 were treated with only oral steroids, and the rest required anti-tubercular treatment. So this I would like to discuss one case. It is a 48-year-old female patient who presented to us in 2014 with an initial presentation which looked like AMPI. We had treated her with topical and oral steroids alone. 3 weeks later, her vision had improved. You can see that the lesions are resolved. However, 4 years later, she came back with a drop in vision. There was a choroiditis lesion that you can see along the inferior temporal arcade. The MON2 was positive. The quantiferon was negative. So we treated this patient with ATT and oral steroids. She was better. However, 2 years later, she came back with a resolution of the TB choroiditis at the same location. And this time we also performed a PCR, and the PCR was positive for Mycobacterium tuberculosis. So now going back to our study, a Fisher extract test was performed to assess the association between the recurrence of AMPI and the diagnostic revision, and the p-value was found to be statistically significant. So it is very fascinating to note that even in the 3 cases that were described by Professor Gass, case 1 and case 3 also had a positive tuberculin test, and case 2 had a positive family history. The father had pulmonary tuberculosis. And literature also shows that some cases of AMPI have been reported in patients with positive tuberculosis tests, especially the first, which was published in a British Journal of Ophthalmology. This patient had pulmonary tuberculosis, and another case report that I've mentioned here. So to conclude, AMPI may be the initial presentation of ocular tuberculosis, especially the recurrent cases, and all AMPI should be closely monitored for recurrences even after initial response to corticosteroid therapy. Thank you.
Nice. So what were your basic treatment for a patient with AMPI? What is your treatment basically?
So I know that literature says that even if you observe it, it resolves. But
how
in
are you
most
treating?
we are treating all our patients with oral steroids.
Oral steroids. What duration and what dose?
Visalone, we taper it from 50, maximum 60 kg based on the patient's body weight to at least 6 weeks.
And then they all resolve over that
They
6
all
weeks.
resolve,
So if they're
most
not resolving, then you're thinking of this.
Yes.
So do you feel that there's a confluence of AMPI and serpiginous-like choroiditis? You feel that there's a, now it's coming closer to that?
Maybe
like?
because the pattern also is kind of
Yeah.
a little...
How do you comment about the treatment modalities for both the things? Because it looks like a continuous spectrum. For in serpiginous choroiditis, you would not leave it for 6 months. You would treat it for longer. Even in VKH, you would treat it for longer. So how about this? Are we sticking to 6 months or less?
I think 6 months at least, and follow up the patients closely so that for any recurrences.
So your take-home message would be after revising this, your diagnosis were revised to TB. So would you prefer to do a MON2 first, then starting steroids before?
Yeah, definitely. I think we screen the patients, do MON2 and quantiferon, and then
only start for all APMPP cases.
Yes.
Yeah, so now you're screening all your APPMP for TB, is it?
Yes,
Am I
we are
right?
screening them for...
Yeah.
So would you follow the same pattern which was recommended earlier in the talk, like the 3 tests, HRCT chest, interferon gold and MON2, or only MON2 you will?
No, we do. If there's a suspicion for TB, then definitely we do MON2, quantiferon, and CCT chest.
And what is your cutoff time when you suspect patient may be suffering from tuberculosis? Because you're already treating patient on the line of APB.
I'm sorry, can you repeat that?
You already treating the patient on the line of APME. When do you consider that cutoff line for you when you think that patient may be suffering from tubercular antigen, and then you are supposed to go for diagnostics?
In this study, only the patients who had come back with a recurrence, we had seen that there was TB, but this was a retrospective study. So
what
going
is the
forward,
cutoff line? Suppose you already put the patient on the treatment. Now, when do you think, okay, now this is time I'm supposed to move on to my second strategy?
Maybe if they're not responding.
That's what. What's the duration for you? Not responding, maybe months or years?
So for AMPI, I think 2 to 6 weeks they should resolve. But if between 2 to 6 weeks they don't resolve, then definitely.
So that's the standard time which you're giving for all the patients, right? Not before that you are thinking of it.
I think we should add it as a part of workup of MP patients. Tuberculosis should be added. Normally, what we were doing was MP, okay, let's not investigate. No, we should.
Because same way, if it's get delayed, again immunomodulation will come.
True.
We don't want that,
Yeah.
right?
No, but one point I want to bring out, since I'm a senior guy on this, I think JDM gas had found everything that is to be known in macula before OCT came or anything came. I think, I don't know, he had some OCT eyes, just want to bring out that point, yeah. Thank you so much.
Thank you.
Thank you. So I would call upon the next speaker, Dr. Alisha Sirsika, presenting on primary intraocular lymphoma, a wolf in a sheep clothing.
Good morning, everyone. My name is Dr. Alisha Sirsikar. I am postgraduate at Narayana Netralaya. I'll be presenting a case series on primary intraocular lymphoma. So, as we all know, primary intraocular lymphoma is an uncommon subset. It is classified into vitreoretinal, choroidal, and iridial. Amongst vitreoretinal, DLBCL is the most common. And here I'll be presenting a case series of 5 primary intraocular lymphoma cases. This is a cross-sectional retrospective study of age group around 26 to 74 years, done over 10 years. And we have taken primary intraocular lymphoma cases based on clinical and histopathological findings. These are my results. So one patient was known case of CNS lymphoma. He was treated with chemotherapy, radiotherapy, and intravitreal methotrexate. And while doing on subsequent MRI brain and orbit, we saw regression in enhancing lesions. Another case was COVID-19 positive. He was a case presented with panuveitis. He was treated with IV methotrexate and systemic chemotherapy. On FFA-ICGA, we saw hypofluorescent areas with window defects. Next patient we treated with De Angelis protocol, vitrectomy, and IV methotrexate. My fourth case was treated with CHOP regimen and De Angelis protocol with radiotherapy and intravitreal methotrexate. PET scan showed DLBCL positive and AC tab showed atypical lymphoid cells. My last case was known case of CNS lymphoma. He was treated with RMVP or MTR regimen. He was MYD88 mutation positive and AC tab was also positive along with immunohistochemistry. I'll be presenting 2 cases briefly. First case was chief complaints of floater, decreased vision, and occasional double vision since 2 weeks. In this fundus image, we can see the creamy white lesions along with vitreous haze. And the key features noted in this case were MRI showed regression of enhancing lesion, and there was pseudohypopyon, white clumps in vitreous and fine capes, and vitreous membranes. On FFA, there was in right eye disc and peripheral staining, left eye shows diffuse perivascularly with ERM staining, showing active inflammation. B scan shows a few vitreous debris with vitritis. This is the first visit OCT. These are the anterior vitreous cells. This was KPs. This showed pseudohypopyon. And this was the AIOS2025-Free image where KPs can be seen along with pseudohypopyon. On AC tab, malignant cells were seen. This patient was managed with both numerous methotrexate injections, and systemic symptoms were controlled with supportive therapy. This was before and after images of the OCT. And PET scan showed regression of enhancing lesions. This was again before and after of fundus image and the pseudohypopyon, which was resolved. So next case, patient complained with blurring of vision in right eye since 2 weeks. We can see the mottling pattern in the fundus image, and key features were FAF shows leopard skin pattern. There was increased subretinal fluid, RPE mottling, and vitreous cells were seen. B scan showed few vitreous opacities. And these were my OCT images, series of OCT images showing sub-RP hyperreflective dots. And these are my series of fundus images, which shows hypo and hyper, alternating hypo and hyperpigmented areas. FAF showed leopard skin pattern in both eyes. Vitreous aspirate IL-10 by IL-6 ratio was 2.5, which was more than 1, showing malignancy. So in discussion, due to diagnostic hurdles, ancillary histopath investigation like IL-10 or IL-6 AC-TAP or MYD-aided mutation are to be considered. Whether systemic treatment should be initiated in isolated PVRL or not. So there was a large clinical research study of 83 PVRL patients without evidence of brain involvement. They found no difference in relapse. So systemic therapy posed greater toxicity without overt benefit. In conclusion, so we have a guarded prognosis, especially when the case involves CNS, and ancillary investigations like biopsy or imaging studies should be considered. Minimal signs and symptoms at presentation, so can't entirely rely on clinical presentation. This is a masquerade that, so you should keep open mind and you should be able to change your diagnosis over time. Thank you. These are my references.
Yeah, we'll go to the next.
Dr. Radhika, please come on the second podium because we are running
Late, yeah. Please come. So Radhika will be speaking on sight imperiled, addressing mum's associated uveitis. And Dr. Girish is there.
Please be ready so that as she finishes.
Dr. Girish Gadre. Yeah. Yeah, I think so. Yes,
Ma'am, they are selecting.
ये लोग गाली देंगे.
Yes.
Start. बेटा.
239. Okay. Good morning, everyone. Today, via this case series, I'll be addressing mum's associated uveitis. The first patient of ours was an 8-year-old male residing in the southern state of Karnataka, presented to us with sudden painless diminution of vision in both the eyes for the past 3 days. He had a history of systemic fever with swelling near the neck 2 weeks prior to the development of his ocular symptoms. He was vaccinated up to age according to the Indian National Immunization Schedule. On further inquiry, the patient's sister also had a history of mumps associated parotitis. On ocular examination, his best corrected visual acuity was hand movements in both the eyes. Intraocular pressures were normal. Anterior segment showed presence of pigments on the corneal endothelium. Sluggish pupillary reaction. AC was quiet. On fundus examination, he had mild temporal dyspallor in both the eyes, and what we noticed was the presence of this multifocal cerebriform pattern of retinitis along the vessels with perivascular clearing present in all the quadrants in both the eyes. OCT showed the presence of posterior vitreous phase cells, distortion of the retinal architecture, and hyperreflectivity of the inner and outer retinal layers in both the eyes, along with loss of foveal contour. Considering the clinical history and ophthalmic examination, a provisional diagnosis of bilateral outer retinitis secondary to mumps virus was made. An empirical dose of oral acyclovir 400 milligrams was started and was referred to the pediatric neurologist to rule out any CNS involvement. His CNS examination was within normal limits. However, his MRI-weighted T1 axial scan showed hyperintense bilateral parotid gland. CSF analysis was normal. Ancillary blood investigation showed a positive serum mumps, IgM and IgG levels. So, considering his systemic history with findings of multifocal retinitis, OCT showing distortion of the outer retinal layers, supported radiologically and serologically, a diagnosis of bilateral outer retinitis secondary to mumps virus was made. The patient was then started on intravenous methylprednisolone 500 milligrams per day for 3 days, followed by a course of tapering dose of oral steroids 1 milligram per body weight. 1 week post his IVMP treatment, the vision did not improve. It was still hand motions in both the eyes. However, the fundus examination showed resolution of the retinitis lesions, but the OCT still showed presence of posterior vitreous phase cells and distortion of the outer retinal layers. Considering that there was no improvement in vision and OCT is still showing presence of distortion of the outer retinal layers, a trial of hyperbaric oxygen therapy as a rescue therapy was considered in this patient with continuation of oral steroids. What hyperbaric oxygen does is it increases the partial pressure of oxygen from 21 to 23%, increasing the nitric oxide synthesis, thereby increasing the transfer of oxygen to the tissues. After ruling out any ear, nose, throat, or respiratory infection, a 2.5 atmosphere absolute oxygen was administered to the patient for 1 hour by direct respiration per day. This was one session, and 40 such sessions was given to the patient. Post the hyperbaric oxygen treatment, his best corrected visual acuity in the right eye was hand motions, whereas in the left eye it improved to 6/9. His intraocular pressures were normal, anterior segment was quiet. Fundus examination still showed mild temporal disc pallor, but the patient developed these nummular lesions all over the retina. IR autofluorescence showed hyperautofluorescence. OCT post-treatment, in the lower panel we can see that the posterior vitreous cells had resolved, the foveal contour was normal, restoration of the inner retinal layer, but there was still mild distortion of the outer retinal layers. Full field ERG showed undetectable scotopic and photopic response in both the eyes, whereas multifocal ERG showed light response only in the central area. A tear cytokine profile was done using a biopath M finder, which showed pre-treatment there was raised cytokine levels, most of it which reduced post IVMP and hyperbaric oxygen therapy. We saw 2 more patients with similar in the similar age group. With a systemic history of fever with bilateral neck, having counting fingers close to face in one eye, in one patient, and hand motions in the other, with a similar presentation in the fundus. In addition, these patients also had a bilateral optic nerve involvement, and one of the patients also had encephalitis. They underwent similar treatment, but unfortunately, they had poor visual outcome. So, if a patient presents to you with a systemic history of fever with bilateral neck swelling, and you see a cerebriform pattern of retinitis, most likely it is secondary to mumps virus, and since there is no specific treatment antiviral available for mumps, the patient can be started on intravenous started on anti-inflammatory therapy, which might reduce the inflammatory load and probably patient might have a good visual outcome. As we say, prevention is better than cure. Inclusion of mumps vaccine in the national immunization schedule, along with measles and rubella, may protect the child from developing this visually debilitating condition. These are my acknowledgements. Thank you.
A very fantastic presentation. Yeah. Very good. Thank you.
Thank you.
Dr. Girish, please.
No. Last, sorry. गाली दे रहे हैं हम लोग, गाली दे रहे हैं. Shit.
Which one? Which one?
Slides देना बेटा.
Last.
Please start the slides fast.
Yeah. I'm presenting clinical profile and management of 57 presumed ocular tuberculosis. 57 cases of presumed ocular tuberculosis were diagnosed on the basis of clinical feature plus any one of positive Mantoux test more than 10 millimeters or quantiferon TB gold or definitive signs of pulmonary TB by chest X-ray, CT or PCR on AC type. All cases were seen in southern Konkan area of Maharashtra in 3 years with a male preponderance and average age of 46. Excluded 4 cases diagnosed as HIV or already treated for toxoplasmosis, retrospectively received, and all received 6 months of ATT were only included. Constitutional symptoms were noted. Clinical findings were divided into anterior uveitis, intermediate uveitis, posterior and pan uveitis, retinal vasculitis along with a patch of choroiditis, neuroretinitis and endophthalmitis with a patch of choroiditis. These are few cases, different types of clinical presentations, strongly suspicious of presumed ocular tuberculosis. So clinical presentation, the most common presentation was posterior uveitis, in which multifocal choroiditis was most common.
The diagnosis was done with a 47% has positive TB gold test, 39, that is 92%, had a positive Mantoux test, 7% had systemic problems suggestive of tuberculosis. Only one patient already received treatment of the active pulmonary TB cases. 3 patients had Mantoux negative but quantiferon gold positive. 4 patients has Mantoux test as well as TB gold negative but PCR was positive. So definitive signs were seen in 9 cases. 8 cases had definitive signs of active tuberculosis and 5 cases had definitive signs of pulmonary tuberculosis. So the investigation protocol we followed was, when we have a strong suggestive of ocular tuberculosis, we do Mantoux test first, followed by quantiferon TB gold test. If it is still negative, we go for PCR for ocular fluid in addition to CT chest and X-ray. So visual outcome, final base corrected visual acuity was better than or equal to in 38 out of 57 patients who completed at least 6 months of ADT. Of remaining 19, 12 lost 1 line vision and 5 lost vision more than 3 lines. Of that 5 patients, all of them have lost vision because of macular scar or edema. All received ATT for 2 months followed by 4 months of 2 drugs regime. 10 received subtenon tricort, 35 received systemic steroids, 12 received intravitreal bevacizumab, 4 laser for NV and 2 had undergone pars plana vitrectomy. Out of 12 cases, those who received anti-VEGF all had macula threatening lesion, 5 had secondary CNVM, 6 had choroiditis lesion threatening macula, 1 had macular edema post-occlusive vasculitis. Single dose of anti-VEGF helps in regression of inflammation and macular edema. 6 patients need more than 2 dosages. Can avoid use of systemic steroid and help in better effectivity of anti-tubercular medication. Anti-VEGF has a role in tuberculosis which has been defined in many journals now. These are few cases where patient had a multifocal choroiditis, then developed macular lesion with a CNVM, which was completely regressed with the 2 dosages of anti-VEGF, and we could, he was a one-eyed patient and could revive his one eye. So role of anti-VEGF causes significant, tuberculosis causes significant inflammation. Inflammation is sometimes more damaging to eye than infection, particularly if it is vision threatening where macular or optic nerve is involved. Systemic steroid may be relatively contraindicated in active TB. Local intravitreal anti-VEGF has a rational use along with a systemic tubercular medication. So to conclude, ocular TB, even though rare, needs to be diagnosed with appropriate test and clinical criteria. Mantoux, quantiferon TB, PCR gives us clue for diagnosis, gives best clinical and visual results if started in time with ATT and steroids. Anti-VEGF has a rational role in sight-threatening lesion. Thank you.
Very nice, doctor. I think a good presentation. Thank you so much, doctor. Thank you.
Very nicely pointed everything.
Yeah.
Thank you, Dr. Girish.
Doctor, yeah. So we have Dr. Samendra.
The next presentation of Dr. Samir.
Yes, sir, last, sorry. So he's the winner of the first Uvea round. His topic is adalimumab in pediatric NIU, efficacy, compliance, single center experience in central India.
Thank you, sir. I have no financial disclosures to make. Pediatric uveitis incidence is 4.3 per 100,000 population and prevalence of 28. It is 20% of all uveitis cases globally and significantly impacts the quality of life because it starts much early and the patient has to live with uveitis for a very long time. Several studies have clearly demonstrated the efficacy of adalimumab over other immunosuppressive agents alone in managing uveitis, and there has always been a need for alternative therapy in children in order to reduce steroid burden, induction of early remission and maintaining remission, non-daily dosing and minimizing side effects. The purpose of our study was to assess the efficacy of ADA in pediatric chronic non-infectious uveitis and evaluate treatment compliance. The efficacy was evaluated based on inactivity on fluorescein angiogram and ability to maintain remission without corticosteroids. Treatment compliance was evaluated based on producing the empty box of injection during next visit if it was given at home. The study design was retrospective. There were 14 eyes of 7 patients. Patients below 16 years were included and the mean age was approximately 12 years. 4 were males and 3 females. Children cooperative for Optos wide field angiography and OCT were included. No history of prior surgery or implant. Age below 16 years. No history of prior immunosuppression or failure to achieve remission with same. Diagnosed to have chronic course of uveitis and failure to achieve remission in last 1 year without corticosteroids. no infectious etiology during workup. Children who required multiple immunosuppressive therapy for systemic vasculitis were excluded. Children not cooperative, previous history of use of biologicals with poor compliance or default were excluded, and unavailable history of immunization or active or dormant tuberculosis were also excluded. Prior corticosteroid exposure was universal in all cases. The cases of JIA with chronic anterior uveitis were 2. 1 case of Blau syndrome, 2 with Behçet's associated panuveitis and vasculitis, and 2 with pars planitis having macular edema. Adalimumab therapy was started in conjunction with methotrexate. Methotrexate preceding 2 weeks before starting adalimumab therapy. Initially, it was fortnightly dosing, followed by increase in the interval of injections after assessment on fluorescein angiogram. All patients underwent complete ophthalmological evaluation and workup and were cooperative for imaging. Infectious cause, especially tuberculosis, was aggressively ruled out in all cases. Diagnosis was established after thorough examination in collaboration with a rheumatologist, and all patients were started on a combination therapy. The remission was achieved in all cases between 6 to 10 weeks. Except one case, which was a case of Behçet's associated panuveitis and vasculitis. This patient could not achieve remission despite 12 injections. Mean follow-up duration was 15 months. 2 patients were lost to follow-up. However, they had achieved remission before losing to follow-up, and they were being followed up telephonically in their local place. Mean injections received were 7. All patients received adalimumab, followed by which was preceded by methotrexate. The side effect profile was also acceptable, and it was seen that adalimumab can be an effective option in pediatric uveitis and achieved remission in majority of our cohort. Adherence to subcutaneous weekly regimen was very good during maintenance, and only 1 patient experienced manageable side effects like myalgia, anorexia, and fatigue. This is the picture of the only patient who could not achieve remission despite 12 injections and was very resistant to steroid therapy also. So we are still exploring, re-reviewing this case. So pediatric NIU, it remains a challenge in view of treatment-related complications, complications secondary to failure to achieve long-term satisfactory remission, and ADA with its subcutaneous and monthly maintenance regimen can prove effective in managing this subgroup of uveitis with good compliance. In our study, 100% compliance was noted. Patients were asked to maintain logs during home administration, and they were asked to present empty boxes, and the reminder calls were sent on days of injection. So early initiation of biologicals could provide early remission, and ADA is efficacious and encourages good compliance due to subcutaneous and less frequent dosing, except some patients reporting some stinging sensation with injections. That's about it. Thank you.
Cost of injection is borne by the patient?
Cost of the injection is borne by the patient.
What would be the approximate cost?
Sir, there are several schemes, and now with the generic medications, approximately 10 to 12,000 per injection.
So, per patient, you had 7 injections approximately.
Approximately.
So 80 to 90,000 the patient had.
Yes. Yes. Many of them were covered by insurance also, so somehow we could.
Thanks, doctor. Thank you so much. Thank you. Very nice. Thank you, everyone.
Thank you everyone for patient.
And sorry for the delay. Sorry for the delay. Very sorry. No, it's okay. Come.